dilated with 3, 3.54 depending on the IVUS finding. And this is the, after post dilatation we could achieve the good result at this stenosis segment. The area was on the lower side 3.14 millimeter square at the stenosis segment, and therefore before putting the stent we did the OCT as well to look for what's going on wrong. And this is the OCT. You can very well appreciate the deep cut over here. And this is the calcified 360-degree arc of calcification at this particular. So this is basically a focal napkin ring calcification which created the problem, which couldn't be appreciated with the angiography. And then ultimately it was stented, post-dilated with a good result across it. And this is the final angiographic view, and the OCT is fine. So I'm just skipping my second presentation, and let me go briefly about my last one more case. That's interesting. Can you end up? Yes, please. So 64-year-old chronic smoker with non-QMI, clinical examination unremarkable, ECG showed ST depression in V4 to V6 lead, and this is the angiogram. See, with the TROP-T which is positive, one can think about that possibly it's a thrombotic lesion over here. So it's been dilated with 2.5 20 millimeter balloon. And now see the OCT. So how many calcified nodule is there? This is the number which is coming over. You can very well have a look on. So this is what the OCT is. There are multiple 8 calcified nodule across the distal to proximal LAD. So it was dilated with 2.75 10 millimeter cutting balloon, and then the OCT was again repeated to look for various crack. You can very well appreciate the cuts because of the cutting balloon. At this moment of time, patient had a TME2 flow, hypotension, and therefore hurriedly the stent was deployed across the LAD. And this is 415, 3.5, 48, and 2.75, 38 from proximal to distal LAD, overlapping drug-eluting stent, post-dilated with 3, 3.5, and 4 millimeter NC balloon from distal to proximal end. Good angiographic result. And this is the OCT across the stented segment. So you can appreciate this number of the calcified nodule, which was 8 initially. To certain extent, some of the calcified nodule could be compressed very well with the cutting balloon followed by the NC balloon. So out of the 8, we had now 4 residual nodule, and then what the area we have achieved across them, 6.95, 9.67, 10.47. So these are the area which is good area after having the balloon dilatation across this calcified balloon. And this is the check angiogram at 9 months of follow-up, patent stent across the LAD. We also had now OCT done, which is well across the distal to mid and mid to proximal segment. So in conclusion, the stent expansion in heavily calcified lesion can be facilitated with the various adjunctive lesion modification technique, and ultimately one has to have a calcium fracture prior to put the stent across, which can be done by, say, NC balloon, cutting balloon, and various ablative therapy. Initial two cases, napkin, the first case, the napkin ring focal calcification can be missed fluoroscopically, but then imaging could very well help help to have now identification of such type of lesion. Imaging do help in quantification and guiding the treatment for the calcified lesion, and it's essential to guide the treatment of ISR when the luminal or abnormal peristrand calcification is present. Thanks for the kind attention.
Thank you, Rajesh, for your wonderful presentation and overall review of calcium management. So we have time for maybe one question and then we switch over to our next talk. Okay, thank you.
I think he showed that beautiful case of napkin ring that didn't get expanded. And one of the treatment of under expanded stent because of calcium is stent ablation with the rota. And in OCT, we could see that stent was absent in that segment.
Yeah.
So it got ablated with the rota ablation, and there was crack behind that.
Yeah, but it is an off-label treatment, but still,
So that is one of the, and another thing that we could use in that scenario was again a laser with contrast. That is where it is quite
That's
handy.
right. But whatever you do, sometimes nothing works, and then you have to quit.
Yes.
Thank you, Rajesh. Thank you.
Finally, Dr. Abhiram Prasad.
Yeah. This is also a very important talk from Professor Abhiram Prasad, who has a lot of original work on the physiology part, and this is something which probably is not being practiced properly in a right perspective in our country. This is what is my personal opinion, and I think we should really focus, and we will discuss even on the live case today. Yeah.
Thank you, Tejas. It's really a good pleasure to be here. And what I wanted to do was change gears here a little bit. And many of the young faculty probably are not even familiar with the trials that made the foundation of FFR and so on, because this technology has really been around for a very long time, so much so that we just accept it for what it is. So what I wanted to do was just cover some of those pieces of evidence, and Tejas asked me to make this practical. So what I've done is really cover 12 points, if you like, rather than sort of go by each trial one by one. So let's go through these, starting by point number one. What is FFR? And I certainly don't want to insult anyone's knowledge or intelligence, but it's an important question. It's the ratio of mean distal pressure to mean proximal pressure. Well, we know that, but the issue is that it actually involves venous pressure, the actual equation. So if we don't think about that in our routine practice, it may be one of the reasons that why we get spurious results in some patients. It's been equated to PD over PA because the vast majority of PCI patients have normal venous pressure or near normal venous pressure. So be aware of that as one of the reasons you might be getting inaccurate numbers. The other thing I want to point out is that the threshold of 0.8 is not really a hard threshold. It came out of the FAME trial series, but the original validation of FFR was done for a value of 0.75. So the reason I mention that is because if you measure an FFR that's 0.79, you're not obligated, or even 0.78, or even 0.77. Really, if you want to pick out patients with really ischemic lesions, its value's close to 0.75. So it's worth bearing that in mind, although 0.8 is what is widely accepted as the threshold. So point number two, routine FFR during angiography doesn't add anything. I think this is an easy one to get out of the way. It's been studied very carefully in this trial, the report trial that was published last year. 17 UK centers, just over 1,000 patients with relatively low-risk disease. And they reported that whether you measured FFR across every lesion, which is kind of an unusual trial to do. I mean, I don't think we typically worry about 30% lesions, but that's what they did. Any lesion more than 30%, they measured FFR in the FFR arm, and otherwise the angiography arm was managed standard of care, and there was no benefit in routinely measuring FFR at the time of angiography, not PCI. So I think it's what we would have expected, but what this trial has told us now for sure. Point number 3, FFR can help defer PCI. This is the foundation of why this technology, pressure wires, are used, and this was studied in the defer trial. Unusual design by today's standards, but if you look here, they randomized patients with an FFR of more than 0.75, randomized them to medical therapy versus PCI. So they actually did PCI in patients who didn't need it. This was at the time that the pressure wire was first launched, and we needed to establish this kind of data. And not surprisingly, if you did angioplasty in people who didn't need it, they didn't do so well. So deferring PCI has good scientific grounds based on the cutoff of 0.75. Point number 4, FFR-guided multi-vessel PCI is superior and cost-effective. Now, this is an area that people have strong feelings about, but there is data to support that from the FAME trial. Now, the FAME trial was published many years ago, but really was a landmark trial where patients, just over 1,000 patients, were randomized to PCI versus angiography-guided, to FFR versus angiography-guided PCI, and this was the outcome. You notice that the curves separated very early, which is kind of interesting. So the value of FFR was early, not late, and that was related to peri-procedural events predominantly. And after that, there didn't seem to be any significant improvement. So the FAME trial is the only trial that provides this evidence. It's one trial. And there was no additional benefit when follow-up was continued out to 5 years. In fact, the curves started coming closer together again, and the significance was lost. And the reason pressure wires work is this is the table that compared the number of lesions in both groups, and the randomization was pretty good. Same number of lesions, 2.7, 2.8, but the number of stents used was much less, reduced by 1 stent per patient. So this is why pressure wires are cost effective. They actually, the reduction in stent use makes up for the cost of the pressure wire. So in summary, the advantage of using physiology is that it treats only lesions that should be treated. It avoids the complications of unnecessary PCI, although you may say PCI in your hands is very, very safe. But with the aging and complex cases that we see, I think it is valuable to avoid unnecessary PCI. And as I just said, it reduces resource utilization. So what are the disadvantages? Why aren't people doing it? In fact, can I have a raise of hand? How many people do pressure wires routinely in their practice? So there's more than perhaps we think, but you need to get used to using adenosine. There's some time and cost involved, and there are technical issues that we'll get to in a moment just to make sure that we're familiar with how best to use it. So what about IVUS guidance? IVUS guidance, we've been talking for a weekend here on imaging and how effective it is. Could it give us the same information as FFR guidance? And indeed, yes, in simple lesions, I believe, in proximal simple lesions, imaging may be good enough to detect lesions that are significant. And this trial compared randomized patients who had intermediate lesions to either FFR guidance, if the FFR was less than 0.8, or an imaging guidance arm with IVUS, where if there was a cross-sectional area of less than 3, which is very similar to that OCD trial that was shown earlier, or if it was between 3 and 4. So the areas have to be really small to be treated, and if it was between 3 and 4, the plaque burden had to be more than 70%. And if you did this, the outcomes were similar. So you can get pressure wire type results with imaging, but please note these were low-risk patients, syntax score just 10. So I don't think we can go around using imaging to say, well, I'll measure a cross-sectional area in a complex disease patient, and that's the same as doing FFR. It is not. And again, if you use FFR, you do much less PCI. If you use imaging, you do a lot more PCI. So while you get same outcomes, it's probably cost effective to use FFR. Point number 6, PCI should be performed in patients who have an FFR of less than 0.8. Should we always be doing it? And I've said probably. The reason for that is the FAME2 trial, which again, for the younger members in the audience, the fellows, you may not have really seen this published. Randomized trial comparing medical therapy to PCI in patients who had at least one lesion that had an FFR of less than 0.8. So I think of this as the COURAGE trial, medical therapy versus PCI, but every patient had an ischemia-producing lesion at least. And what you see is that PCI was superior. So you would say, well, that's the end of the story, but of course this was a composite endpoint, and when you drilled down, it wasn't due to differences in death or MI, it was largely due to rates of revascularization that was different. And this, remember, was an industry-sponsored trial. There was some controversy around this trial, and when you look at the details of what drove the urgent revascularization, it was unstable angina, which is a soft endpoint. When it comes to death or MI, there was no difference. So in fact, you could treat patients medically even when they have FFR, and you actually do very well. What's different is this urgent revascularization, but this was an open label trial. The patients, the physicians all knew that there was an FFR less than 0.8, and the patient had been randomized to medical therapy. So that's why I don't believe that this trial is the final word on whether we should treat everybody with an FFR of less than 0.8. This is the 5-year outcome, and the curves remain separated in favor of PCI. This is actually more interesting for our contemporary practice, point number 7. Even with contemporary PCI guided by FFR, CABG remains superior. This was shown recently, published last year, the FAME-3 trial, which tried to replicate syntax trial, but in this it tried to take the two limitations of syntax out by using FFR in every patient and using second-generation stents. And despite that, the outcomes were better with CABG. So this is confirming what we've known with Barry trial, Freedom, and syntax, that surgery remains the gold standard for 3-vessel disease. But if you drill down on this data and break it down by syntax score, it confirms what we know in our practice, that you can treat simple 3-vessel disease with PCI, in fact, get better results. The blue line here is PCI. Surgery actually did worse when patients had low syntax score. This was also seen in the syntax trial. So I think the guidelines should change and are changing, in fact, in favor of PCI for simple 3-vessel disease. So the FAME-3 trial, I think, did inform our practice. What about optimization? Can you optimize? We spent this weekend again talking about image-guided optimization. You would think you could, because if you measure FFR post-PCI, in 20% of patients, it's still below 0.8. So it gives us valuable information, and we know those patients do poorly. The reason this has never been studied is because the reason for that poor FFR after a stent, even a beautifully deployed stent, is diffuse disease, and it would take a very, very large trial to show that FFR optimization actually works to improve the stent site. So in general, poor FFR distal to a beautifully deployed stent is due to diffuse disease. So no evidence for stent optimization using physiology. So based on all of that, for stable disease, currently there is a class 1A recommendation for using the pressure wire to assess intermediate lesions. So what about ACS? Can we use pressure wires and newer IFR indices for that? And the answer is you can, but it probably is not very helpful. There's actually only one trial, the FLOWER trial, that in STEMI patients, which randomized patients according to a guidance of angio versus FFR for non-culprit lesions. So they did primary PCI and then did the randomization of the non-culprit vessel to FFR versus angio, and there was no improvement in outcomes, which is unlike in stable disease, where I just showed you that FFR improves outcomes when compared to angiography guidance. So I think in the ACS population, things are very different, and we'll come to why that might be in a moment. So point number 10, what are the pitfalls of physiology? And there are many. And there is a learning curve, and I think sometimes people get frustrated using pressure wires because they don't get the numbers they're expecting. First of all, adenosine delivery it needs to be secured, so IV is recommended in general, but intracoronary can be used. And the reason in ACS things don't work out is the microvasculature doesn't dilate, right? So if you don't dilate the microcirculation, you're not going to get hyperemia, and if you're not going to get a hyperemia, you're not going to get a FFR value that's accurate. The same is true for non-STEMIs, severe structural heart disease, heart failure, as we mentioned earlier, with the issue of right heart pressures, can all give you spurious results with physiology. Even remember that things like diet, theophylline, caffeine can act as an adenosine antagonist and fail to cause microvascular dilation. This is technically a very important thing, guide damping. This happens more often than you realize. You give the IV adenosine, you create this increased flow into the coronary, and that sucks the guide in. And once that happens, you actually get this ventricularized tracing, both distal and proximal. They're overlapped, and there's no gradient. FFR appears to be normal. You disengage the guide, and now you have a very abnormal FFR. So I think guide damping is a major issue. The other is drift. I think this is by far the commonest. Despite the technology being around for so long, even the current wires are really prone to drifting. So on the top we have what a real FFR should look like, an abnormal FFR. There's this deep diastolic gradient. The tracing looks ventricularized, the distal pressure. This is what drift looks like. So you have the aortic pressure in red, you have a dicrotic notch, and the distal pressure looks identical. You still have the dicrotic notch there, the pressure tracing doesn't look ventricularized. This could be a very mild lesion, but more often than not this is drift. In fact, in my practice I find that virtually I have to do this 2 or 3 times. The drift is really an issue. So you go and measure the pressure, the gradient, you come back, you check if there's been drift, and very often there has been. You go back in and measure it again, and until you're confident that there's no drift, do not accept the value. So drift is a very important thing. This is a really interesting study where they looked at the relationship between the vessel and the guide size, and showed that if the guide was too big for the vessel, even when the vessel was actually normal, you got spurious values. And what they did was they measured FFR before disengaging. So they engaged here and disengaged. And in 1 in 5 patients, the FFR value went from being normal to abnormal. So watch for too big a guide in a small vessel. So what are the reasons when the FFR is higher, in other words, normal, than you expected? Well, adenosine delivery, make sure the IV is working. Damped tracings, we talked about. Drift, we talked about. Here's another one, contrast. The techs always tell you, or the reps of the company, flush the guide, and that does matter. The other issue that's under-recognized is tandem lesions. If you have a severe stenosis distally to your lesion of interest, you will not get hyperemia, but the lesions have to be severe. It's not any tandem lesions. We're talking about lesions that are 80-90% stenosed in tandem. That's when your FFR across your proximal lesion is not going to be accurate. So you have to treat the distal lesion if needed, if clinically indicated, then remeasure the proximal lesion FFR again, and often the FFR will drop because you're now getting much better hyperemia across that vessel. What about the opposite situation? The FFR is lower than you expected. Most commonly this is drift, but spasms, so always give nitro before measuring, always do that. And then the uncommon but unfortunate complication of dissections. This will happen if you do enough, because you start pushing the limits of these wires. They're not as friendly as our workhorse wires, and they can cause dissections. And then diffuse disease, and we were talking about that. Small vessels, diffuse disease, one of the reasons why in your practice here you may find that the FFR is really not abnormal when you should expect it to be. The vessels here, of course, are smaller, and so a little bit of mild diffuse disease, smaller vessels may not be causing hyperemia. That could be one explanation. So in conclusion, FFR-guided PCI improves clinical outcomes. We talked about that, FAME 1, FAME 2, FAME 3 trials. But this is primarily achieved by reducing unnecessary PCI. Angiographically, we have the oculostenotic reflex, and we need to try to get away from that if we can. So point number 11, moving on to non-hyperemic indices, it's fair to say that IFR is equivalent, and in fact, most of us are now using IFR routinely. That's really our go-to because it's quicker, cheaper, with fewer side effects because you don't have adenosine. So what is IFR? This is the diastolic ratio. This is a proprietary ratio for Philips Volcano. They decided to measure it at 25% into diastole and stopping just before the end of diastole, and they measure the gradient here. The rationale for this is that the natural resistance is minimal at this point of the cardiac cycle, and so it's like giving adenosine without giving it. So you get a gradient that is representative of what the lesion is all about. Now, as you know, there are many non-hyperemic indices available now. Abbott have a whole cycle index, and then Boston and Opsens have their own. Thankfully, they all use the cutoff of 0.89. Can you imagine if they used different cutoffs? It would just be, impossible to think about, or talking to each other about what we're saying, even communicating about what we mean about a lesion. So this they got wise about. The other point I want to make is, even though they've all been marketed as if they're all the same, they're not all the same. They have never been validated. Except for IFR, none of the others have been validated in large clinical trials. They've been essentially been shown to be equivalent for correlation curves, but they have not been shown to be equivalent to FFR in clinical trials. I mean, I think by implication they probably are, but just be careful about that. So 2 trials that were done with IFR that launched the index really into everyday clinical practice, we felt comfortable. So IFR Sweetheart showed that the outcomes were similar whether you used FFR or IFR, and the outcomes remained so out to 5 years. So the benefit of using IFR, or the equivalency or non-inferiority, was out to 5 years, so long-term benefit. And same was seen in DEFINE, where patients were randomized to either an FFR-guided strategy or IFR-guided strategy. The outcomes are identical. So I think we can be very comfortable putting the FFR away and sticking to IFR. It really makes you use it much more too, because it's so much easier and convenient. But remember that these trials of equivalency were done in low-risk patients. So if you have a complex lesion set and you get an IFR that you don't really believe, then do our FFR, because these trials have not shown that the two are equivalent. They should be, but they've never been shown to be equivalent in complex disease. So, for example, they excluded left main, and so recently this registry was published, the left main IFR DEFINE, which showed that probably it is reasonable to use IFR even for the left main. What about pullbacks? Because and with FFR, that certainly wasn't easy to do. Philips have this co-registered version of their pullback, and it plots where the gradients are, and it shows you where the maximal drop in gradient is. I will tell you that, frankly, we have used this, and none of us really found that it added to our practice. And it was a little time-consuming. Hopefully there's no Philips reps here. But, so we stopped using it, even though we have it. But I do believe that this technology and this concept will continue to improve. I think the co-registration part of it just needs to improve, and I think it will come back into our routine practice. And I think for younger interventions, this sort of technology is really good, because it kind of teaches you about angiography. But unfortunately, most of us are rather old or getting old, and I think we've done a lot of time with looking at angiograms, and I think this doesn't add much to us yet. All right, final point. What about discordance? Much has been talked about. So FFRs, normal IFRs, and what does that mean? You know, people worried a lot about it. In fact, for the first 2-3 years when we measured IFR, many of us did both. And we only stopped doing FFR when we were comfortable that the clinical information we were getting was similar. And so the studies so far, the observational studies, have shown that the discordance is not associated with any bad clinical outcome. So even if you have discordant results, it seems that patients overall do equally well. What are the reasons for the discordance? Well, if you take this discordance, so the FFR is normal and the IFR is abnormal. This happens in situations about limited hyperemia. We've talked about that already, where the microvascular is dysfunctional, you're not getting hyperemia. So the FFR is abnormal, but the FFR is not. And you see that in the elderly, structural heart disease, diffuse CAD, populations like diabetics and peripheral arterial disease, kidney disease, those patients, you get this sort of discordance. What about the other way around? FFR positive, but IFR negative. This happens in patients or individuals who just have really good hyperemia. Young individuals, if you measure it in the left main or LAD, you may get this sort of situation. Or focal lesions. Another phenomena is pressure recovery. If you measure an FFR that with the sensor right after the lesion, there's still not laminar flow. The pressure is artificially very low just distal to the lesion. You need to push the wire further out where the laminar flow returns, and the true distal pressure is measured there. So you need to be about 3 or 4 millimeters distal to the lesion. And this happens in very tight lesions, not all lesions, and you get this pressure recovery phenomenon. So you'll get an abnormal FFR when it really shouldn't be. Push the wire forward, the actual FFR will drop a little bit. So I think we have a better understanding of factors that cause this discordance. And I'll leave you with these take-home messages that we've already covered in our 12 points, and stop here and be happy to answer any questions. Thank you very much.
Thank you very much, Abhiram, for a wonderful overview of physiology. I think the problems which we were toying with in our mind, I think you have already answered in your talk, but any of you, if you want to have questions, you can ask him. Yeah, please.
Regarding the protocol FFR, the IV or the intracoronary protocol you prefer?
Well, I think if you read the guidelines, it's IV to ensure good delivery. It allows you to do pullback. If you wanted to do it with FFR, you can do pullbacks with IV. But in practice, in our practice, we very often do intracoronary. But that used to be historically. Now we've switched to IFR, so we just don't need to. But I think if you really want to do it properly, IV is the way to go. But it's more expensive, a little bit more time consuming.
Regarding the papaverine?
Ooh, never used it. There are side effects, potential concerns around that.
And can you focus on angio-guided FFR and CT-guided FFR?
Yeah, I had a slide. I took it out because I'm no expert on that. FFR CT, I have great concerns over. I think it's a black box, right? The images get sent off somewhere else, and they give us the FFR CT, it is what it is. And I think it's very image dependent. So if you have a radiology department that gets really high quality images, you probably will get good FFR CT, but we have seen plenty of examples, and it may be referral bias, but we've seen examples where the FFR CTs are really off. We for a while we were measuring it, when they would come as whatever they were, we would do a proper FR, invasive FR, and the correlation didn't seem excellent, I would say. So to the point that I think in clinical practice you need to use your own judgment, go back to the angiogram and your own invasive assessments. I would not guide all your decision making off a CT, is my personal feeling. It's very helpful. I think, people in the chest pain population, if you take the whole population of chest pain, I think FFR CT and CT angiography is excellent in the ED, for example, emergency rooms. But once these patients make it to our clinics and to an interventionist, I think that's infrequently. I think it's good for ruling out in normal coronaries, but beyond that, I don't use CT or FFR CT. Now, QCA, that's really an amazing potential, holds a lot of promise. We don't have first-hand use of it yet, but as you probably know, you need multiple views, you need to spend some time doing it. It probably will be yet another add-on, but will it replace invasive FFR, IFR? I'm not sure yet.
So last question, Abhiram, what is your intracoronary dose of adenosine for right and left in your lab?
That's of course a trick question. We typically use 60 to 120 for the left. I think yesterday you mentioned these really super high doses, and I have never done that. I mean, there are studies that showing that you can get lower and lower values of FFR, but again, because we've gone off to IFR now, it's become less of an issue.
This dose simply doesn't work in our lab. Why, I don't know. And we are using 300 mics for the right and 600 mics for the left.
That's I don't know if you don't why you don't routinely get
I can show you today. I'm going to do the live case. We will show that today. Yeah. Last.
What is the optimum hyperemia? Everyone talks about the optimum hyperemia. So we give adenosine till the bradycardia or something happens. So what is that?
What is the optimal hyperemia?
Yeah, he means that would you expect straight line with FFR and then you evaluate, or what?
Well,
or so very severe bradycardia.
Yeah. Did you have a question?
I think I have a very basic question I can ask you offline if we have time constraints. But most of the FFR original validation was done with exercise nuclear imaging,
yes,
which in and by itself has major pitfalls,
yes,
with artifacts, etc., and false positive ECGs and everything. So has anybody thought of doing revalidation with PET type imaging, which is more accurate?
I'm not aware of anybody doing. This is a great example of how practice develops, right? So we used a suboptimal gold standard to validate the FFR, then changed our cutoff from 0.75 to 0.8, and now validate the IFR to the FFR, and CT FFR has been validated against it. So this story keeps going on. So I think you're absolutely right. I mean, it's time that we kind of go back and
very
look at
quick
all this.
because we have constraint of time. Yeah.
That's why I want to ask Gosti.
Yeah.
Only one question.
Yeah, just go ahead, please. Last one.
Sir, sorry, since I'm leaving.
I have one,
Gosti.
announcement. After this question, we were supposed to disperse for a short coffee break. But before that, I think we will finish 2 short presentations of our national guest faculty, which were supposed to be there after live demo. And then 10 minutes of coffee break, and then we will go ahead with the live demo till lunch. Okay? Yeah.
Simple question, sir. Actually, a procedure, post-procedure difference between the imaging and the FFR. If the FFR is not correct, but post-imaging MSA is good. In such a case, what will you take?
The imaging.
Yeah, imaging is good.
Yeah.
But FFR value, you are doing it, but it is not coming up.
So
Imaging is acceptable.
Yeah, it is variable.
It's a big lumen, but
Yeah,
FFR is abnormal.
Yeah. So that's what I'm saying. You accept the imaging result as your end. You're done. Because the only concern would be, is there a problem with the stent? So if there's no dissection, no issues with expansion, it is because of diffuse disease. That's why you're getting it. It has to be. And so that's why it's never been used for optimization, because early on when it first came out, there was this thinking that we should be using it. And it comes up as a topic every so often, studies come out every so often, but it's never been shown to be clinically useful. I would go by imaging to optimize stents. Absolutely.
Thank you, Abhiram. It was a great presentation. So, yeah.
Dr. Chirag Seth.
Yeah, this will be two quick presentations and on how the imaging saved my day by Chirag Seth and then Tanuj, I think. The other 3 national guest faculty could not come because they missed their flight because of the last evening problem. Yeah.
So good noon, everyone. Thank you, Dr. Patel sir, for inviting me for this talk, and it's indeed my pleasure to be at this meeting. So quickly going to the 2 cases that I wanted to show. Refer to the talk by Dr. Akasaka and Dr. Vijay Varghia. My 2 presentations are based on their talks. So first case is of a 55-year-old male who is a chronic smoker who has underwent DES implantation to LED 1 month before. It was done for anterior wall ST elevation MI. And DAPT non-compliant somehow for a week before the index, second admission. He was admitted with anterior wall reinfarction and acute LVF. LVF had dropped down to 30%. And after some initial medical stabilization, we planned for a repeat angiogram, and this time with considering possibility of a stent failure and IVUS assessment. So what we see here is a stented segment in the LED showing zero flow. Index PCI, it was a 3 into 19 millimeter drug-eluting stent in proximal LED, and it was non-ostially placed. It was not image-guided PCI in the index episode, and this patient was now taken up for assessment. So initially after balloon daughtering, after passage of wire, there appeared to be a thrombus at the proximal edge, and I have shown a frozen image on the second image on the other side. And thereafter we performed an IVUS evaluation. So for some time I will just play the IVUS run. From distal to proximal, here the stent starts coming in. You can see that it is very well opposed in the distal part. As you come more proximally, you can see the vessel size growing. That media to media size starts growing. And as you come more proximally, the thrombus starts becoming apparent. There is possibility of specific calcifications also. And here you start seeing the calcium. So stent so far appears to be well opposed, and now you can start seeing the proximal LED, which is showing lipid-rich plaques with almost evidences of some attenuations. So this is all proximal LED showing significant disease. This is point of confluence, again showing some small speck of calcium, but a significant plaque burden there as well. And this is distal left main, coming back to proximal one. So this is what the IVUS picture was of the LED pullback. So snapshots, if we review again, the distal stentage and mid segment appeared to have a stent size appropriate according to distal vessel size on IVUS. A 3 mm base was well opposed with adequate stent area, and there was no distal edge dissection. But proximally, if you see, the stent was undersized, though it was well opposed, and there was large lipidic pull with some evidences of attenuation in the proximal LAD, and a plaque extended across the POC into distal left main. Size in the proximal LAD was approaching almost 4 to 4.2, and we can see that for that size, the stent was, though well opposed, it was undersized. So these are snapshots of ostial LAD, then going to next the distal LMCA and coming more proximally. It shows that there is disease burden in the distal left main also across POC extending into the ostial LAD. So it was clearly a geographic miss in the first index PCI with large amount of lipid plaque burden in the proximal LAD, and added to that probably there was DAPT non-compliance which led to an event with a stent thrombosis. So we decided for a crossover stent from LMCA to LAD this time. We put a 4 into 19 millimeter drug-eluting stent. Pot was done with a 4 millimeter NC balloon at high pressure, at 18 atmospheric pressure, but we remained careful that we did only in the left main, did not come into the LAD, fearing that high pressure balloon dilatations there in the LAD probably would lead to slow flow, no flow situations. So we just deployed at nominal pressures and did a pot in left main only. And one can see a final result that the flow was established. One can see that distally still in the distal LAD the flow is poor because of thrombus migration despite doing this. Though hemodynamically the things could be stabilized and he could be sent home. This is the post PCI IVUS pullback from LAD to LMCA. So again, the distal stent is not a problem. Things are more or less okay. There is one focal area where the stent area was here that required to be optimized, and that was done with the help of NC balloons. Apart from that, the old and new both stents were fine without any proximal edge dissections. And these are the post PCI MSAs. Optimally obtained in the proximal LAD about 9.4 and in the left main about 11, and toward the proximal edge about 12.4, indicating optimized result as far as IVUS guidance is concerned, and the geographic miss was corrected this, and the patient could be sent home safely. So optimal sizing of vessel diameter for stent selection is not uncommon in acute STEMI situation. Most often we undersize the vessel because of that milieu in which there are so many vasoconstrictors there, and therefore we undersize that vessel, and often we don't do post dilatation aggressively, fearing that there can be slow flow, no flow. So these are the things which can happen commonly in the ACS situation. So malapposition, especially with under expansion of the stent, it leads to early MACE rates. And stent landing zone in the segment with high lipid arc and plaque attenuation is also responsible for early MACE, and probably that was the cause in this patient. IVUS assessment and optimization in the index PCI could have led to prevention of this event, and this underlines the importance of imaging in ACS situations. And of course, the DAPT compliance is essential in preventing the early stent failure. Coming to next, 74-year-old female, diabetic, hypertensive. She underwent stent to RCA for inferior wall ST elevation MI. It was in 2005, and a repeat intervention was done in 2007. We did not have records what stents they were and why the repeat intervention was done in RCA, but probably it may have been because of some new lesion formation in RCA. Second interventions were done in circumflex and LAD in 2016 and 2019 for episodes of unstable angina thereafter. She was DAPT compliant, and she again got admitted almost 15 years after the index inferior wall MI with again repeat acute inferior wall ST elevation MI this year in April. Ejection fraction was good, creatinine was 1.4, and this was the RCA showing. It was instant restenosis in proximal RCA, and the stented segment showed a complete occlusion possibility of some bridging collaterals we can see, and the distal flow was almost TME1. Left coronary angiogram showed that the stents were patent in LAD and circumflex without any proliferation or instant restenosis. Completely clean left system. And here we are dealing with a very late stent failure, almost more than 15 years. And possibly it is because of new atherosclerosis and a plaque rupture. So it was a tricky situation to deal with. If there were lesions on the other vessels also, probably decision making would have been very easy, and we could have electively sent her for CABG. But since it was just RCA disease with stent failure, we thought we'll go ahead with OCT evaluation and see what the image we get and how to manage. So this is the baseline OCT that we can see. So of course this was performed after initial balloon dilatation with NC balloons and cutting balloon, and thereafter OCT run was obtained because this lesion behaved really like a chronic total occlusion to start with. So it was like a acute on chronic occlusion that happened, which led to ST elevation MI. So as expected, this is a clear-cut example of a new atherosclerosis. Starting from distal to proximal, one can clearly see that there is so much of calcification that we can see. There are evidences of heterogeneous nature of atherosclerosis here. You can see even 2 layers of stent here, significant amount of fibrosis, and as you come more proximally, you can see lipid-rich plaques as well. So if I show you the snapshots apart from this run, here comes the lipid layers. So this is distal to proximal. I have divided this three. The first row is the distal 1/3 of the segment, middle row is the middle 1/3, and the last row is the proximal 1/3. Starting from distal to proximal, you can see that here there was, the first image shows here that you have good amount of healthy tissue seen here, except for 12 to 3 o'clock position with some degree of calcification. And by the third image, you can see the evidences of plaque rupture. Dense plates of calcium is seen in this image, and 2 layers of stent very well evident in the middle row, with evidence of heterogeneous tissue distribution. And as you come more proximally, you can see a calcific nodule here. You can see evidences of thrombus. Here you can see a lipidic plaque here. And here again, in the most proximal portion, you have a thick plate of calcium with a reasonably preserved medial architecture and relatively healthy looking landing zone proximally. So this is how the overall picture of this RCA was. So what are the treatment options for this kind of ISR in a 15-year-old stent? So heterogeneous diffuse knee atherosclerosis with a plaque rupture. It was inferior wall STEMI, heavy calcification, calcific nodule proximally, 2 layers of stent with adequate MSA in the index PCI. If we assess more closely, the index PCI stents were all adequately expanded, and that's why I think for 15 years nothing has happened. So whatever stent failure this time the patient had, it was more because of biological factors and not stent related factors. So the options in these patients are what? One is plain balloon angioplasty with NC balloon, OPN balloon, and just leave. Second, drug-eluting balloon, whether one should put a drug-eluting stent. And of course, these are the 2 modalities which are advocated in stent failure, brachytherapy and laser. So last 2 options were not available. If you look into the data with others, then there are high MACE rates, irrespective of modality chosen, almost as high as 15 to 20% in 9 months. And almost that curve tends to diverge as the time passes. So recurrent event rates are much higher. And with 2 layers, of course, almost always someone says that no third layer should ever be given because recurrence rates are very high. But what do you do for this kind of patient? So all studies have been done with 2nd generation stents. We don't have any data with 3rd generation DES versus DEB. Initially, we were inclined to just consider DEB and leave it at this patient. But since the patient had plaque rupture and had an inferior wall MI, again, we chose to err on the safer side for the patient safety. And we thought that accepting the recurrence rate of 25%, we will still go ahead with the stent. So after, as I told, the lesion behaved like a CTO, so fine cross, then Grand Slam guide wire, and then pre-dilatation with 3 and 3.5, Wolverine cutting balloons. We deployed a Zions 348 stent, and post-dilated with 3.5 NC balloon, and one of the areas which were not giving way, we used with the OPN, and this is what the final result that we could achieve angiographically, and this is what the OCT picture shows. So almost reasonably good areas that we could achieve. One focal point had an area of about 4.22 millimeter square. We wanted to achieve it about 4.5 millimeter square and more. So again, we had done balloon dilatation there, but I must say that it was only marginally successful. But rest of the artery, we could achieve good areas, and the result was good. So management strategy for very late stent failure, more than 15 years due to plaque rupture and new atherosclerosis causing MI is of course complex and debatable, and I think we don't really have very ideal answers how best to manage them, and we don't have randomized data from the studies as well. So calcification, especially the nodular one, and the heterogeneous nature of new atherosclerosis needs advanced modalities. I think all those aspects have been covered in the previous talks, and it just underlines the complexity of the situation that we are facing with. And yes, OCT is essential in PCI optimization in any kind of stent failure, whether it is early or late. And I think these two cases are important as far as this message is concerned, that any stent failure, imaging provides added information as far as management is concerned. Thank you for your patience.
Thank you, Chirag. I think it was a fine presentation, and I have one request to make. By the time Tanuj presents, I am preparing the case. You guys can come and with a coffee and sit here, and we can start the last session, as soon as possible once I reach there, right? Yeah, thank you. Tanuj.
Good afternoon, everyone. So I would be stressing on both how imaging and physiology saved my days. All the cases actually saved the day. They had treatment outcomes that changed according to their presentation. And conventionally, we have been using either physiology as FFR assessment for chronic coronary syndromes, and more likely to use imaging for acute coronary syndromes. But this is a very reductive approach, especially because ambiguity still engulfs the clinical classification. We are still learning the progression and regression and the pathobiology of atherosclerosis. And one size fitting all approach is not true. I would be exemplifying through example. The first example is about angiographically indeterminate lesions, and though we have a wealth of long-term data for FFR for assessment, but we should understand that egg dissection, suboptimal expansion, stent malapposition definitely flies beneath the FFR radar, and FFR is extremely unreliable in ACS and serial stenosis, just as discussed in a few presentations earlier. And now we have an upcoming trial where OCT would be helping us predict FFR. But this fundamental question still needs to be answered. This case would exemplify that. This was a 54-year-old post-angioplasty to LCX and OM diabetic male. He presented to us with unstable angina. The stent in OM was patent. The vessel distal to the stent in LCX was critical disease, but the myocardial value of that territory is not great. You can see a osteoproximal LAD lesion, and in the epicranial lesion, epicranial view, you can see the tandem lesion in mid LAD. So we were more interested towards managing the LAD because that had two serial stenosis, and we started with the FFR that was 0.72 towards LAD, and hence we thought we'll first address the left anterior descending artery. In presence of two serial stenosis, we addressed the distal. We assessed it on the OCT first, and we documented that the MLA was more severe in the distal lesion. It was 2.53, and the proximal lesion had a MLA of 3.90 millimeter square, the osteoproximal LAD lesion. And hence we fixed the LAD lesion first, post-dilated with it with a 3x10 NC balloon and subsequently got a FFR of 0.87. Now let's focus on the proximal LED, osteoproximal LED lesion. This had a MLA of 3.90 millimeter square. The plaque is eccentric. You can appreciate the healed plaque. The fibrous cap is pretty thick. The inflammatory markers, you can appreciate the signal rich, confluent, punctate speckles that are attenuating the OCT light. These are M2 macrophages. Even the macrophages have been divided into two subsets. One is the classic macrophages that are actually pro-inflammatory. They have a lot of lipid and hence they are kind of appearing as shadows. The another is what we just showed was our M2 macrophages. They are actually anti-inflammatory and they may appear bright because of the high intensity mitochondria and they cause a background shadowing across them. And the sensitivity of these increases, especially if they are located deep, like in our case. So these were, we left this plaque as such and the patient is doing well for the past 3 years as of now. We have already discussed the tussle between FFR and OCT in such situations. It was a very small trial that randomized patients to FFR or OCT guidance. We had already discussed it earlier, and the primary endpoint was pretty improved with the in the OCT arm. The second subset where imaging and physiology might really help is what is evolving concept of non-culprit lesion in ACS, whether the plaque is vulnerable. So this case is extremely, it was an eye-opener for me. It was a 52-year-old male presenting with chest pain for 3 days. I'll emphasize on the history and I'll like everyone to make a mental image what's happening with the patient. The troponin was borderline positive, echo was normal, ST changes were not very dramatic. So we labeled it as a non-ST elevation MI. Please look at the angiogram very carefully, although it does not show much. The LAD's got mild disease, the left circumflex is a very small vessel. So this is the right coronary artery. This was the only lesion that appeared simple to me. You can please see the date, it is 19th April. I did the case approximately in the morning around 11 a.m. and in the night around 3 a.m. my resident called and he said the patient is having severe chest pain. So much so that I scolded him that it's ECG of another patient. You don't, the LED was normal, I was sure. And no, this was a clear surprise. The LED had occluded in hospital for this. You can see the comparative images of 19th April and 20th April. So this is a 1-day gap. The patient has had a MI in hospital and we did a thrombosuction aggressively. I wanted to image the artery. So this is after the imaging. The proximal LED where it was occluded after thrombosuction, you can appreciate the plaque is extremely mild. The calcium is just in one quadrant and that too not very protrusive. At between 4 to 6 o'clock, you can see a fibrofatty plaque. You can see the calcium at between in the right upper quadrant. You can appreciate the mild lesion of the nature, and this is what caused the MI, the total occlusion of the artery. And though we have a very clear definition of TCFA, the vulnerable plaque on OCT, but we have not discussed the TCFA on IVUS in our routine discussions. So by IVUS, fibroathromas are defined, like in this case, by just a 10% confluent necrotic core that is abutting the lumen in just 30 degrees, and this should be present in just 3 consecutive frames, like in our patient between 4 to 6 o'clock. And this was what caused an acute event within the hospital. And as we discussed, and we are still discussing the OCT predictors of plaque vulnerability, we have now data from combined OCT FFR trial in which FFR negative patients were randomized, were followed up on the basis of TCFA presence on OCT. It is just a observational assessment when the patient is diabetic and having TCFA versus whether the patient is having diabetes and no TCFA, the MACE is 3.6. When the patient has TCFA, the patient has a hazard ratio for MACE of 2.4. So these two subsets we really need to be focused on. Definitely there are a lot of limitations with this trial as well. Okay. So we should focus on what patients actually we should be focusing to find the vulnerable plaque. As of now, a high calcium score on a cardiac CT, a low attenuation plaque in patients with stable CAD, and definitely diabetes mellitus alone has a twofold risk of MI. So it is our choice whether we wish to skate on that thin ice or document those vulnerable plaque with accuracy and then approach them. Another limitation of imaging and physiology is definitely what we do it in our routine practice. Sometimes with imaging we are over treating, and sometimes with FFR we are under treating, and this is a persistent dilemma. My next case is a 48-year-old anterior wall MI patient. She presented in a late presentation as usually is the case. So sorry. So we did a crossover stenting from LM to LED because it was a critical disease. I wish it should move. It was interesting. Yeah. So in this we did a crossover stenting from LM to LED, and below. Maybe I can't say. Yeah, below, further down, further down. Okay. Yeah. So this was a crossover stent, this was an acute anterior wall MI patient. You can appreciate the distal LM bifurcation osteoproximal LED lesion. Since the LED lesion was critical, we did a crossover stenting from LM to LED. It was a long segment lesion, mismatch of diameter proximally and distally. And the LCX, thereafter we made the LCX ostia after the crossover stenting. I would just focus on the bifurcation view of the LCX ostium. You can appreciate the stent struts across the LCX ostium, but with the relatively wide ostia of the LCX. The pullback from the LCX documents a ostial MLA of 2.53 millimeters square. This is the ostial LCX. The plaque burden was approximately 60% and the FFR was 0.86. We have a beautiful paper by Sujin Keng et al. That shows that a pre-procedural MLA at LCX ostia, if it is more than 3.7 millimeters square, it virtually excludes the possibility of a functional LCX compromise with a crossover stenting. However, if it is the converse, even then the possibility of having a occlusion after crossover stenting is just 15%. So these cases we should follow up with a post-stenting FFR. In such cases, we even documented a FFR in subsequent setting when we did PCI to RC in this patient, and we got a FFR of 0.92. My last case would exemplify the combination of these two. This was a 57-year-old male, a high bleeding risk patient, past history of hematemesis, esophageal stricture, presented to us with unstable angina. So the left side angiogram shows a severe disease in distal LM bifurcation, but that extends into both osteoproximal LED as LCX. The stenosis in LCX is a very long segment stenosis. You can appreciate the mismatch between the osteoproximal LM and the distal LM. The diameters are dramatically different. The bifurcation is involving both the branches. And I gave the patient an option of CABG. He did not agree. He was insistent, and we planned. We had a lot of challenges. The discrepancy between the sizing of the vessels, which vessel should I assume to be the side branch? What would be my target endpoint? Would it just be an angio? Would it just be FFR, or it would be more than that? And since the patient is HBR, we just want a perfect result. So we started with a baseline FFR of 0.79 towards LED, 0.77 towards LCX. The IVUS pullback from left circumflex showed the distal LM MLA was 4.9. Osteoproximal LCX had a heavy fibrotic plaque burden 62%, MLA 3.1 millimeters square. Similar findings in LM from the pullback from LED, and the MLA in LED was was 2.98 millimeter square. Appreciate the LM MLAs 3.9 millimeter square as compared to EM in proximal LM that was 23 millimeter square. So these were the challenges. We deployed a DES 3.5 into 48 in distal LCX, used the same balloon for osteoproximal LCX dilatation, a cutting balloon because of the fibrotic nature of both osteal LAD and osteal LCX lesion towards both branches sequentially, and then with a T strategy with a very wide angle, 3.5 into 33 DES in osteal LAD and 4.5 into 34 from LM to LCX. And thereafter, we did post dilatation, a pot, recrossed the wire, repot with a 5 millimeters balloon, did a final kissing of pot again with a 5 millimeters balloon, and this is the not final result, this is the result thereafter. Took the IVUS pullbacks, documented the stent expansion. Osteoproximal LCX stent was slightly under expanded. LM was satisfactorily having a MSA of 15 millimeter square, but there was still a malapposition of 32% with a lumen area of 21 millimeter square. So we can't follow the conventional textbook rules for all patients. We did a FFR, this was 0.90, and these days we have another strategy known as PIOS strategy, the physiology guided incremental optimization strategy, where we can go for additional balloon dilatations if our FFR was less than 0.90. So we did a pot seeing both the IVUS and FFR. We did a pot with 6 into 8 mm balloon, and let's see how it improved the MLAs and FFR. We got a step up from 0.90 to 0.93. This was the final FFR, and we got a step up of MSA from 15 millimeter square to 18 millimeter square. But that was the maximum that I could achieve with the 6 mm balloon. So we've again conventionally used FFR before PCI and OCT after PCI. That is also slightly reductive, and with the evidence from the target FFR on the PIOS strategy, let's not pitch FFR and OCT against each other. We can use a pre-PCI evaluation by both FFR and PPG index, pressure pullback gradient index, then a pre-PCI and post-PCI evaluation, and try to document, especially not in diffuse lesions, but in non-diffuse lesions, to document a post-PCI functional evaluation by a FFR for our final result. So I would conclude by saying that FFR and OCT represent the yin and yang of coronary intervention. They are perfectly complementary, and they are better together rather when they are separate. Forza and combined OCT trial, they open a door towards understanding these and the use of these methodologies in borderline lesions, as well as target FFR trials tells us that we should use both these modalities in the best way whenever it is available. And in times to come, it would not be just anatomy and functional variables. We might even look towards biomechanical variables, like in my second case, the endothelial shear stress that might be high in the proximal LAD that caused an acute MI even in the hospital setting. Thank you very much. Thank you.
Thank you very much. It was an excellent presentation showing the fine symbiosis of physiology and imaging. Are we ready for the live case, or do we have any time for questions?
We'll be having a 10-minute coffee break and then
Okay, so let's take 10-minute coffee break. We'll ask questions offline and then come back on time for live case. Thank you.